我们第一位邀请的嘉宾是 Jessica Monaghan， 她是来自于澳大利亚国家的声学实验室 NAL 的资深研究科学家，曾经是剑桥大学的神经科学硕士、诺丁汉大学的电子工程博士，曾经在剑桥大学的听力神经组、英国医学研究委员会、南安普顿大学和澳大利亚麦克瑞大学担任研究员，曾经利用深度神经网络和稀疏编码发展了降噪算法。目前主要的研究方向是应用机器学习技术解决听力保健中的问题。在这一次的话，我们还是依旧采用原来的方式，采用录播加上中文视频、中文字幕的方式来完成这一次的分享。也非常感谢来自香港大学听力学的在读博士生王上奇郭帮我们完成了这次翻译的中文的校对部分。稍等一下的话 ，Jessica 会参与我们的 Q&A 环节，所以大家可以把问题做一下准备。
Hi, I'm Jessica Monaghan from the National Acoustic Laboratories in Sydney, Australia. Today I'm going to talk to you about machine learning for audiology.
Okay, so to start, what is machine learning? Well, machine learning is an approach to analysis in which computers learn patterns that are present in data rather than being pre-programmed with specific rules. Then these learned patterns or trained models can be used to make predictions when they're provided with new data. I'm also going to use the term artificial intelligence, and one definition of this is when humans are able to mimic human behaviour. This can include machine learning, but it doesn't have to. For example, if a chatbot is programmed to respond in a particular way to certain phrases, then this could be regarded as artificial intelligence, but it wouldn't require any learning.
So, why do we need machine learning for audiology? Well, in many countries across the world, there is an ageing population, and that means audiologists' time will be in increasing demand. By 2050, the World Health Organization predicts that 1 in 4 people will have a hearing problem. We can use machine learning techniques to increase the accuracy and efficiency of diagnosis of hearing problems, and even to identify people with hearing problems before they reach the clinic to make assessments more targeted. It can also be used to monitor changes in listening behaviour, which may indicate problems either with people's hearing devices or their hearing aids, or changes to their hearing, which may indicate they should return to the clinic for further assessment. By applying machine learning, we can allow audiologists to have more face-to-face time for appointments for these uniquely human activities such as discussing hearing goals and counselling clients. And we know that this is what clients really value in their audiology appointments, is this kind of interaction.
So I'm going to be illustrating ways in which machine learning can be applied to audiology using projects from NAL and also externally. I'd like to start by discussing a project I'm currently leading at NAL, identifying hearing loss from children's speech.
The speech that we used in this study was obtained from participants in the longitudinal outcomes in children with hearing impairment study that's been ongoing at NAL for many years now. As part of the tests that they undertook at 3 years old, there was a speech production test called the DEEP. In this test, children are shown pictures and they're prompted to identify what's shown in the picture. So, for example, here, elephant, girl, lighthouse are some of the words that are used. For each test session, it was recorded, and that's what we used as the material for audio analysis. We had speech from 110 children with hearing loss and 39 normal hearing children who were part of the control group for the Lockheed study. The speech needed to be manually isolated because the recordings were of the whole test session, so it contained speech from the speech pathologist and sometimes also the children's parents. And so we manually isolated all of the words produced by the target child in each test session. And then at the end, we had one audio file for each child containing all of the words that they produced during the test. In order to classify whether the children had hearing loss or not, we first extracted acoustic features from the audio files. The acoustic features that we used, some of them were standard features that are used in automatic speech recognition. So for example, gamma tone cepstral coefficients, which are similar to male frequency cepstral coefficients, raster PLPs, and we also included some statistics about the shape of the spectrum and the fundamental frequency and harmonic ratio of the speech. We fed these features into a deep neural network, and importantly here we used long short-term memory units in the network. And the reason for this is that some of the changes that have been observed between children with normal hearing and children with hearing loss are in the temporal dynamics of the speech. So for example, in the speech production rate and in the onset of particular phonemes. So we wanted the network to be able to capture these kind of differences in the way the speech changed over time, which is possible with LSTMs. When we trained the network, because the dataset was quite small, each time we selected the child to be tested, and then we trained the network on speech from all of the other children. And then we repeated this for each child in the dataset and took the average accuracy. Overall, the accuracy of classification was 97%, and that was fairly equal across the children with hearing loss and the children with normal hearing. So the accuracy was 96% for the children with hearing loss and 97% for the normal hearing children.
So these initial results are very promising, particularly with such a small data set. More data is going to be collected in future to improve the accuracy and generalizability of the network. But it has great potential for testing preschool children and even for older age groups. And also it provides a really unobtrusive and convenient screening approach, as it's something that could be deployed in phone apps or smart speakers, for example.
Next, I'm going to talk about identifying conductive losses remotely. There's been increasing interest in teleaudiology, particularly with the pandemic.
So we know that air conduction testing can be safe and easy to perform remotely. There are even many smartphone apps that can provide good accuracy for air conduction testing. However, it's a bit trickier to test bone conduction remotely. Even if you were able to send out the correct equipment, we know that bone conduction placement can be difficult outside of the clinic, that it requires some experience and expertise. So in this project, we want to see whether we can predict the bone conduction outcomes from the air conduction thresholds alone. So what we're particularly interested in is bone conduction asymmetry. So when there's a difference in the bone conduction thresholds between the ears, and also the air-bone gap. So when there's a difference between the air conduction thresholds and the bone conduction thresholds. And both of these may be signs that the patient requires further investigation, that there might be a more serious pathology that needs to be ruled out.
For this project, we used the dataset of the most recent audiograms collected from patients seen at Hearing Australia. NAL is the research arm of Hearing Australia, which is the Australian government's owned hearing service provider. And it's the largest provider of hearing services in Australia. So we had this large data set of around 900,000 people's audiograms, and for each of these we have the air conduction and bone conduction thresholds. So we're able to identify for each of these people whether they had a bone conduction asymmetry or an air-bone gap. And these were the definitions we used. That if the asymmetry, if there was a difference between the ears of greater than 15 dB at 1 octave or greater than 10 dB at 2 consecutive octaves. And for the air-bone gap, the definition was a difference between the air conduction and bone conduction thresholds of 10 dB at 1 octave. And we saw higher rates of both in this data set, likely because this is a clinical sample rather than a sample of the general population. For the neural network training, we split the audiograms into 90% training and 10% test. We selected a threshold value that gave 80% specificity, so we didn't want too many people to have to go in for in-clinic testing. And this gave a similar accuracy across the three output features. Around 70% for the bone conduction asymmetry and 87% for the air-bone gap. And there was a higher accuracy when we considered more severe asymmetry or air-bone gaps. So that was increasing each criteria by 10 dB. And this gave a sensitivity of around 85% for the asymmetry and for the air-bone gaps.
So this does indicate that air conduction thresholds alone can be used to identify patients at the highest need of further investigation. However, the accuracy was low for less severe findings. But we're hopeful that by pairing this with additional tools such as questionnaires on middle ear symptoms, we can increase that accuracy. An important opportunity exists here for screening patients using self-test or remote audiometry. So this is not currently a NAL project, but I think it's a really exciting way in which machine learning is being applied in audiology today, and something that's going to be really relevant across the world. So the principle here is applying computer vision techniques to images such as this from otoscopes, and using that to identify middle ear disease in the way that an ENT specialist could. And the benefit of this is that it can enable remote communities without ENT practitioners to diagnose and treat conditions without delay. And so this is really relevant in Australia, where in a lot of remote and regional areas, there aren't ENT specialists available, and people would have to travel great distances to be assessed. There have been a number of published studies on this. Generally, the approach is to have a dataset like this of images, which have each been labelled by an ENT specialist as to whether normal, abnormal, and what condition is seen in the image. A number of them report very high levels of accuracy, so around 98% accuracy over a number of different classes of middle ear disease.
And this research is already being translated into practice. So for example, HearX has a beta version available at the moment for their HearScope that can classify an image as normal, wax obstructed, chronic perforation, or abnormal. And this gives a confidence rating for each of the classifications, and also they're working on developing more classes at the moment. Here in Australia, Drumbeat AI are collaborating with Microsoft and healthcare organisations to collect otoscope images from Aboriginal children in rural and remote Australia. And this is really important because they actually have the highest level of middle ear disease in the world. So this shows the kind of interface that's used for Drumbeat. So once the image has been captured, then it's uploaded to the system, and that gives an initial assessment of normal or abnormal and gives a likely diagnosis. So here it gives chronic otitis media with perforation, and then it also gives advice to be taken.
Okay, next I'm going to talk about the NAL NL2 prescription formula. So I thought this was a really interesting topic to discuss because actually this is one of the most widespread applications of machine learning in audiology today. So even though it's been around for a few years, so released in 2012, and it's been deployed millions of times since then. So this interface may be familiar to many of you, but maybe not everyone knows how it was derived. So the goal of the formula is to maximize the intelligibility of speech, but also achieve a comfortable loudness.
And the way that this is achieved is by using psychoacoustic models of intelligibility and loudness. The intelligibility model used is a modified version of the Speech Intelligibility Index, but also incorporating an effective audibility factor. And this is based on research at NAL, which showed that even when speech is fully audible, people with hearing loss, particularly more severe hearing loss, are not able to extract all of the information in the speech. The loudness is calculated from a standard model from Moore and Glasberg, and in here is that the loudness from the normal hearing model must not exceed the loudness by the hearing impaired person. So the way in which the network was trained was to have a large set of different audiograms and 6 station levels of speech. For each of these combinations of audiogram and speech presentation level, to optimize the gain frequency response applied to the input speech in order to optimize intelligibility while also not exceeding this loudness criterion. So the optimum gain frequency response was found for each combination of audiogram and input level using an iterative method. And then these gain frequency responses formed the target for training a neural network. So the input to the neural network was the audiogram and the input level, the input sound level, and the target was the gain frequency response. The network, the formula gives a different gain for tonal and non-tonal languages, and that's because the intelligibility model has different frequency dependency depending on what language is used.
And finally, I'd like to talk a bit about how automatic speech recognition can be applied to assist hearing impaired listeners, particularly in the audiology clinic.
So for this project, we actually created an app, NAL Scribe, that captioned real-time speech. And the purpose of this was to try to make conversations easier and improve speech understanding in hearing clinics. So typically we tested this using an iPad, either at reception or during appointments with the audiologist, and it displayed the text in large font, so it was easy for the clients to read. And we found this particularly useful when staff were wearing masks or behind perspex screens, as happened on and off over the past couple of years. Clients with severe or profound hearing loss found it particularly helpful, and it was very useful in noisy reception areas. So it can be used with a remote microphone or with an external microphone connected to the device. And we found that with the external microphone, then the captions were very clear and accurate, even in noisy areas. In appointments, it was very useful when the client was not wearing their hearing aids, for instance, when molds were being taken. And clients who weren't fluent in English found that it was a real benefit to help them understand the audiologists in appointments. We actually ran a study in 7 hearing clinics to ask clients how useful they found the app in terms of its usefulness to themselves and their general overall impression of it. In general, people rated it between 8 and 9, but we found that their ratings of its usefulness depended on their own hearing loss. So we also recorded that when they gave their survey answers. And here are some examples. So for example, this person with a 3 frequency average hearing loss of 40 dB rated it 10 and said that if the audiologist had said anything I didn't hear, then I picked it up on the screen. And we had a lot of comments like that it was good for confirming what the audiologist was saying in the appointments. Someone with a less severe hearing loss, so a free frequency average of 28 dB, rated it lower, but they said that while they didn't personally need it, they could see the benefit to helping people with worse hearing. And this was a recurring theme, that people could see the benefit to others even if they didn't find it useful themselves. And overall, so people said that they would like to see the technology continue to be available in hearing clinics, and 92% agreed with that, and just 8% said they didn't know. And that's actually available for download now. Here's a QR code, and the transcription is available in Mandarin. Unfortunately, the app is only available for iOS at the moment, but we found as an Android alternative, Google's NAL Transcribe worked very well. Okay, just some final thoughts about the application of machine learning to audiology. I've spoken about a number of different ways that machine learning can be applied in audiology, but the most significant factor in the success of machine learning approaches is the quality and quantity of data used to train the models. Importantly then, the future power of machine learning relies on ensuring that the data collected in audiology and ENT clinics are processed and stored in a standardized way. Machine learning has the potential to use readily available data in new ways, enhancing the effectiveness and efficiency of hearing care. But as with any new technology, we need to take care to ensure that practitioners use evidence-based methods that provide the best possible experience and outcome for their patients. And we need to make sure that machine learning approaches are transparent and free of bias, so as not to disadvantage any patient groups.
I'd like to acknowledge my colleagues who worked with me on these projects. So David Allen, Arun Sebastian, Nikki Chong White, and the Lockheed team who helped with the data for the Children's Speech Project. And thanks for listening.
好的，我们非常感谢 Jess 给我们带来的一个精彩的分享。那么的话，我们也知道，其实那个的话 NAL 的话是属于澳洲国家的声学实验室，在声学界是富有名气的。而且它也是不仅仅它是在声学界很有名气，但它同样也非常关注一项听力损失以及听力学方面的研究。所以我们在刚才 Jess 的分享当中的话，可以看到其实 NAL 对机器学习如何在听力学跟听力损失的研究上面已经做了非常多的运用。包括刚才我听到了一个非常惊人的数据，就是他们有一个将近90万的一个听力图的一个数据，用这个听力图的数据可以做出用机器学习去训练，得出很多他们想要的一些数据跟结果。所以我觉得这是一个很棒的事情。包括对于中耳疾病的一个预防诊断，还有我们很熟悉的 NAL 跟 NAL2 的一个处方公式，原来也是经过一个神经网络的训练，才能实现现在的精准度和有效性。Jessica, are you there?
Hi, yes, I'm here. Nice to see you.
Yeah, we are so glad to have you here to be with us. And we are really happy that slide you showed, you explained how NAL is doing the thing to help to make things much better on the audiologists with the machine learning technologies. And thank you for the. And now we have one question for you from the audience. So can you see the questions?
Yes, thank you. Okay, yes, this is very interesting. So far we have just been thinking about this as a screening tool, and then maybe using it to predict the 3 frequency average hearing loss. But it's an interesting idea to try and use this to fit the hearing aid. But of course, as you say, this would require a much larger training set. So yeah, for that, I don't know if I would change the network, but maybe look at specific phonemes that might give us more of this kind of specific information about what frequencies are not being well perceived that we could then use to fit the hearing aid. So that's very interesting. So I don't know if this is asking about the size of the current training set. So there we had 110 children with hearing loss and 39 children with normal hearing. The structure was this 2-layer LSTM network, and the first layer had, I think, 200 neurons and then 60 units with 50% dropout. And yes, so the performance in the wild, so to speak, we haven't tested this outside of this this data set. So yeah, that's something still to come. But I think first we're going to try and collect more data to try and make sure that this is something that will work in real situations.
Okay, thanks for the sharing. And
thanks very much.
Let me see if there's any other questions. I think we have audience who know you well, and it's Kyle. Yeah, he said he wants to online with you. Let me see if Kyle is on there. Let me check. Oh, Kyle, I saw you, and can you hands up? Kyle, 你可以把那个举下手吗？我看那个怎么把你给开来。Let me have a look. Kyle, 你可以举个手吗？要不我可能没办法把你 Q 起来。Okay, maybe we can have someone who is up. Let me try this one. So this audience, Shang Wang.
Yeah. Hi, Jess. This is Shang. Good to see you again. Thanks. Yeah, thanks for your sharing. Yeah. I'm questioning about identifying hearing loss from children's speech.
Okay.
Is it possible to distinguish children with different degree of hearing loss from the audio data, like normal hearing versus mild hearing loss? You know, we may be able to easily tell the difference between children with normal hearing and moderate to severe hearing loss, but if it's to be used for screening purpose, it is more likely to distinguish between normal and mild hearing loss.
So in this data set, the number of misidentifications was quite small, only 6 of the children with hearing loss. And within that set, it wasn't the case that sort of children that they had milder hearing losses in particular. And what we saw was actually in the hearing loss group, although that some of them tend to be more moderate in general, there were children with mild hearing loss, around a quarter of them. So it was still detecting those kind of mild differences. Yeah, okay. Mild hearing losses.
Okay, thank you.
Thanks for your question.
Okay, so Jess, can you see the screen? There is another question there from the audience.
Yes, I see that.
Yes.
So no, they weren't predicting the bone conduction thresholds directly. It was predicting whether there was an air-bone gap, so whether there was a difference between the air conduction and bone conduction thresholds. So yeah, just a classification task there. So we didn't test whether we could predict the bone conduction thresholds directly.
Okay, so the next questions will come to Yui, who can help to ask a question. I saw someone is asking a question.
Oh, hi, Jessica. I'm interested in the audiogram dataset you mentioned. Is it a public one?
It's not a public one, actually. It's the data from within Hearing Australia. So yeah, I don't think it's likely we would be able to make it public in the near future. But if someone would like to collaborate on a project with us where we were able to keep the data private, then that would be a possibility.
Thanks.
Okay, next I will have Kyle to be online.
Great.
Hello. Hey, Jessica.
Hi, Carl.
How are you?
Very well, thank you. How are you?
Good. Yeah. I came back the last July, so yeah, we haven't met for 1 year. Yeah.
Yeah, that's right.
Yeah. Can you remember the last time I was Tech and Barry? We went to the NAL to see you. So I tried to demonstrate my product to you, but I guess I have no time to do this. Yeah.
Oh no, well, hopefully we can chat about that online.
Yeah. Okay. Yeah, I mentioned to you. Now I want to do the affordable hearing aid in China market. So yeah, now I still I got the first round investment to start my company. So everything is going well. So yeah. But I want to back to Australian, but because of the current I come back. So maybe later I can meet you again.
Wow, I'm glad that's going well.
Okay, that's good. Is there any new engineer joining the team?
We have an app developer who's joined the team, and David Meng, maybe you know.
Good. Okay. Yeah. I want to see you again.
Yeah, me too. That'd be great if you could come back to Australia.
Okay. Yeah. Okay. Okay. Thanks. Okay.
Thank you. Great to hear from you.
Okay. Okay. Yeah. Thank you, Kyle. 简单介绍一下，因为 Kyle 的话，实际上是在 NAL 有当过好几年的一个软件的工程师，他曾经在 Jess 底下Jessica 是他的 leader， 所以所以这也说明中国市场也是进步蛮大，也很多人愿意从国外再回到中国来，然后来做一些不管是助听器的算法或者方案的研究，这说明中国市场越来越被大家给认可跟重视到了吧。然后在留言区的话，刚刚有人可能有问到，因为刚才那个澳大利亚因为有提到他们有大概有将近90万个一个 audiogram 的一个数据，那么其实这个数据确实是他们自己澳洲的国家听力的一个收集的一个数据，目前可能并不是一个很适合公开的一个状态吧，这个我是根据留言区可能做了一个回答。看一下还有留言区还有小伙伴要举手发言的吗？就是希望大家回答的时候尽量做一下中文翻译，因为还是有很多小伙伴可能英文还是听得不是太懂。上网我看到你还有在举手，我再把您 Q 起来好吗？还是那个云Jessica, wait a minute, let me ask somebody to ask the questions. Hello. Hello, 这位观众你好，你有什么问题吗？可以问一下对方 Jessica。Hello。好吧，可能是不小心按到了。OK， 我们也非常谢谢今天 Jessica 给我们来给我们上线 online 做了一些回答，也有一些小伙伴问了一些蛮复杂的问题。所以他们也那个 Jessica 也给我们做了一个很详细的解释。Thank you so much, Jessica. I think this is all for today, and they have finished all their questions.
Thank you, Stella, for the invite. It was really wonderful to get the chance to talk to you all. Right.
Sorry for stepping in, Stella. I've just one more question for Jessica.
Okay. You can go on.
Cool, thanks. Hi, Jessica. I'm Ben. I'm CEO of Orca. We just presented after you, so it was a great honor. NAL has been sort of the benchmark for the industry, really pushing the whole industry forward in terms of really thinking about what audiology can bring to people with hearing loss, and how we as an industry can really enable hearing aids to better serve the people in need. So super inspirational, the talk that you had today. So one quick question that I had was, you mentioned that you guys have been working not only on collecting the audiogram data, but also the image set data on the middle ear part. This is something that we found super fascinating, because when we talk about hearing aids, we always focus on the acoustic part about hearing compensation, but there's also the step, actually the first step, the initial step, where we have to figure out what is causing the hearing loss. You know, it could be some infection in the middle ear or other things that's happening in the eardrum. So, so for us, this is an area of interest, and I just wondering if you can share a little bit more on your thoughts on where you guys see the future is in terms of how we use AI to further understand the middle ear infection and other aspects of the ear science here, audiology. So
thanks, Ben. That was really kind words. So actually, sorry if that was unclear. So that project was not a NAL project, but just something that I also find a really fascinating use of AI for audiology. And I think particularly, so this project Drumbeat AI. So we are actually potentially collaborating with Drumbeat AI to collect more data from Aboriginal children. And I think that that's going to be somewhere where it's going to make a big difference, being able to diagnose these kind of problems in remote areas. So I think that's going to be just a really inspirational project for Australia. And I think it's definitely an area we would be interested in working more in the future. But yeah, I can't take credit for any of that work there. Thank you.
Cool, awesome, thanks. Yeah, we should definitely talk more on that, because you know the same analogy applies in China, where there's a lot of remote areas where it's limited access to good audiology care. So yeah, thanks for the sharing today, and thanks for the answer. 然后那个 Thank you 然后刚刚那个 Stella 那个提醒我了一下，就是不好意思，我刚刚也是Stella 已经说过要翻译一下，然后也刚刚也是忘记，然后就刚刚和 Jessica 简单请教了一下她关于说 AI 如何能够在就是听力助听器验配之前的那一步耳道的检查，然后去看中耳道部分的一些情况。然后这个也是听刚刚 Jessica 的分享里面有提到说，他们就是之前也是跟其他的一些合作机构有一些这一方面的数据集的采集，就是用这个去看耳道的这个图像，去看能够通过计算机去更好的做一些第一步的一些筛查，也是还是回到说去赋能于我们的专业听力师，让他们做他们专业的部分。所以就是刚刚也是请教了一下 Jessica 在目前他们在这一方向的一些进展。谢谢 Stella。
好，非常谢谢 Ben, and also thank you Jessica again. And I think this is all for today, Jessica, and thank you for visit and to make a speech for us.